Good afternoon. Welcome to the second webinar in our new webinar series. Before we begin with Dr. Hodes, there are a few quick housekeeping points. For participants listening in French, select your language on the bottom left by clicking on Floor. To allow and see and follow along with the PowerPoint, click Presentation on the top left of your screen. Feel free to download the slides in both English and French and follow along by clicking in Documents on the right. We will leave 5 minutes at the end for question and answers. In order to submit your questions, click on Messaging, which is on the bar on the right side, and then Participants. I would now like to introduce you to Dr. Deborah Rhodes, who will begin her presentation.
Hello, thank you very much for joining me in this webinar today. As you can see, I'm Deborah Hodes. I'm a community paediatrician in London, and I want to tell you a little bit about FGM and my role in England and particularly our work in London. We are just having a little technical problem trying to get the slides to go because there's another slide that should be coming up. Okay, so I'm going to tell you a little bit about myself and how I got interested in FGM. Many, many years ago when I was a student, a very close friend of mine introduced me to his parents, who'd both been working in Sudan. And this was really in the 1970s, 80s, and his mother told me about FGM and she'd written a little book. So as a medical student, I was very interested. And when I was referred my first case in 2006, many years later, I did think about her and her work and really what FGM meant for people in other countries. So I want to tell you, and we'll have the slideshow up soon. I'm very sorry about the technical hitch. I want to tell you a little bit about the background, the prevalence, our experience in working in the clinic in London in the area FGM, and a little bit about how we are trying to prevent FGM in the UK, and something about our prosecutions. We have, like here in Toronto, a very multicultural society in London and really in the main urban areas all over England. So there's London, Manchester, Liverpool, and many of you might be familiar with other cities in England. And that's where many people first come to when they migrate to England. There has been quite a lot of publicity recently in the newspapers where rather sort of sensational articles about the many thousands or hundreds of women and children who have had FGM and no one's detecting them or caring for them or helping them with perhaps their side effects or distress. And there are headlines in the newspapers, and there might be the same here that you might have noticed. So in fact, how are we thinking about this in the country? So we've really started really since it became illegal in the 1980s to take steps to detect it and prevent it. I want to tell you a little bit about how I think about FGM because of course it is illegal. It's illegal here in Canada, illegal in most countries in the world, not necessarily FGM specifically, but certainly child abuse or some abuse for children. It's very important to think about it from a rights-based point of view, because obviously you could argue saying, well, it's my culture, it's what I do, but it is violence against women and children. And as we know from the United Nations Convention for the Rights of the Child, it is the right of the child to be safe. And if you look at the convention, Article 24, says that parties shall take effective and appropriate measures with a view to abolishing traditional practices, prejudicial to the health of children. Article 19 says that we have a duty to protect the child from all forms of physical or mental violence, injury or abuse, neglect or negligent treatment, maltreatment or exploitation. So if you take a rights-based approach to the issue of female genital mutilation, cutting, which is what the C stands for, that will be a rights-based approach. It is the right of the child, the young person, to be safe from forms of abuse. What is the definition of female genital mutilation, cutting? Well, the best definition to use is that from the WHO, World Health Organization. And they define FGM as comprising all procedures involving partial or total removal of the external female genitalia or other injury to the female genital organs for non-medical reasons. And now I hope you can see the slide, which we have on the screen, which has a definition of FGM. So just before that, back to the outline of my talk, as I said, I'm going to tell you about the types, the prevalence, our clinic, and what's happening in the UK. As I said, from the newspapers and the headlines, you'd think that it was really very commonplace and we'd all detect it very easily. People working in health, in the police, in education. But in fact, from what these headlines say, that there are statistics of people having had it, but we don't know about it. It's hidden and people are suffering because they've had it. So I've told you about the way we think about it. The next part of my talk is really to tell you about what it actually is, because there's an awful lot of misunderstanding about female genital mutilation, cutting. Most people think about it as something that's happened and the woman is stitched up, completely leaving a very small hole. That's true, but that is in 15% of the worldwide population who have had it. That doesn't mean it's not important, because that is millions of women, but it's not FGM for the most part. So it's not necessarily what we in the countries where people migrate to will be seeing. I just want to revise the female anatomy, just to familiarize yourself with the parts and the parts that might be affected. So as you know, there are the big lips called the labia majora, here where my arrow is pointing. Then the little lips called the labia minora. And in fact, in children, the little lips, the labia minora, are very, very small, and they only form here at the top. This is a little hole for the urine to come out of, the hole of the vagina. And here is the clitoris, the hood, and the gland. This is analogous to the male penis, which has the glands at the tip and the prepuce, which is the hood. And that is what is cut, the hood, in male circumcision. But as to so avoid discussion and perhaps an argument about male and female circumcision, which could go on for many hours, one of the ways I think about this is to say that in fact male circumcision is legal and female genital mutilation, cutting, is illegal in our countries. So this is just to remind you about the anatomy. And now to tell you about the types. There are 4 types, 1, 2, 3, 4, and you may think it's strange I'm starting with type 4. But I am starting with type 4 because that's the least invasive, or some people call it the milder type. But of course, nothing which actually harms you in your body and in your genital area is mild, because it is always a trauma. So just looking at type 4, that is when there is a little prick or a cut around the area of the clitoris. And you can see the red line there, which constitutes a cut, which in many children forms a little scar. And this is defined by UNICEF as cut, but there's no flesh removed and there's no sewing. So in fact, when you see a child later, you may see nothing. This is still female genital cutting and is still illegal. What about the other types? So WHO has type 1, 2, 3 and 4. And type 1 and 2 are shown here in the red. And in type 1 you can see the red is around the clitoris and the clitoral hood. And what happens in type 1 is either complete or partial removal of the clitoris. Now very often it is partial, because for people familiar with the anatomy, you might know that the clitoral artery is quite near this area, and of course if it's nicked, then the bleeding can be fatal and the child may die of a hemorrhage. So traditional cutters are very careful not to cause damage that cuts the artery so that the child dies, and that might result in a partial type. Type 2 is more invasive, as you can see from the diagrams, and here, as in type 1, flesh is removed, but you can see it also includes the labia minora, the little lips, which in small children are higher up, nearer the clitoris. They don't extend right down over the whole area. And then sometimes, because there's some bleeding, there needs to be a little stitching just at the top, and you can see a scar. But although there are changes, and it is very traumatic for children to have to undergo this procedure, there is no obstruction to the outflow of urine here because the hole is open, nor for the delivery of the baby, because the baby can come out because the hole, again here, is open and there's no stitching across. Unlike type 3 in the last diagram, where you can see the stitching is right across, leaving a very small opening. And this is what most people think about when they hear about FGM or FGC. But it is, as I said earlier, 15% of the worldwide population who have undergone this procedure. So just to summarize the WHO classification, which I've defined earlier on, there are 4 types. The least invasive being type 4, although that does include other things like labial pulling, which you might hear about, and also very, very destructively insertion of corrosives into the vagina. But for the most part, it is pricking, and 50% of young girls in Malaysia and Indonesia have in fact undergone this procedure. Then I talked about type 1, 2 and 3. I just want to remind you of the complications of this procedure, and as you can probably gather from my description, the more invasive types, type 3, will have more complications. But apart from just the cut or the prick, the immediate complications will be pain, hemorrhage, that's bleeding, and as I said, it can be fatal, infection, and in some cultures the cut and the removal of tissue is healed by the legs of the child being bound together and different things put on the cut to heal it. But of course these might cause infection, and if the child can't pass urine properly and there's urine going over the cut, not only is there terrible pain, but there's an increased risk of infection. In doing the procedure, especially in a baby or a very young child, it's very difficult, despite the children being held down. So there might well be injury to other organs around the area in the genitalia. With the pain and the swelling, there can be retention of urine. In other words, the child doesn't pass urine for a long time and the bladder gets larger and larger. That's very painful, and eventually the child needs to pass urine. And as I said before, because of infection and bleeding, the child can die. And we don't know how many children do die of the complications of FGMC in the world. Long term, there are complications. With the pricking and the cutting, there'd be very rarely long-term complications, although you could get what we call a keloid, which is an abnormal healing of a scar. But there, in the other types 1, 2 and 3, there can be failure to heal, abscesses which never heal, dermoid or inclusion cysts, which are types of cysts in women which can get really enormous, as can the keloids. And of course, depending on where women who have undergone this procedure live, there might well not be any medical care. Recurrent urinary tract infections, bloodborne virus infections, that means hepatitis B, syphilis, and HIV infections can occur from sharing instruments, either blades or needles, to cut, particularly when children are cut in groups. Gynecological problems, women's problems of pain and abnormal sensations in the area, and difficulty in enjoying sexual intercourse if there's no clitoris, or difficulty in having sexual intercourse causing pain if there's been suturing and the hole into the vagina is very small. Obstetric in delivery of the baby, there are more complications than in women who have not undergone the procedure. And psychologically, there may be symptoms of post-traumatic stress. In other words, flashbacks and difficulties having had the procedure. And during the time of procedure, there can actually be immediate psychological problems and also physical problems from the child being held down. So with all this that I've discussed, why is it that people make their girls undergo FGM? Here is a list of some of the misconceptions and the beliefs which are really strongly held in the communities. And this is why it's very difficult to end the practice without getting to the bottom of the cultural aspects of FGMC. As you can see, the social obligation, acceptance, it's often a rite of passage. It often goes with forced and early child marriage. And certainly in Sierra Leone, there's the practice of the bondu, where the young girls of 12, 13 go off into the forest and learn how to be good wives and mothers. And during this process, which can last several months, they also undergo female genital mutilation, cutting. It's believed that it reduces sexual desire. There is a fear of the clitoris in some cultures and sexuality, and it's thought to keep virginity. In fact, it originated at the time of the pharaohs. It's not a religious requirement, which is why it is practiced in many different religions, the Jewish religion, Christian religion, and the Muslim religion, because that's where people with those religious practices live across sub-Saharan Africa, and it was started, as I say, by the pharaohs to keep their slaves virgin and not getting pregnant when they tied up their labia majora, the large lips. Other beliefs include that it gives the girl a readiness for marriage and adulthood, a rite of passage, as I said before. It's thought to purify the body and clean the body, and it's aesthetically pleasing. People will say they don't want those bits hanging down. It's ugly. And of course, one must think now about the fashion, which I'm sure you're all aware about, for labiaplasty. And the demands for labiaplasty have increased dramatically for all sorts of complex reasons. And that is a discussion and a presentation in itself. The other misconception is it protects against material want. So what are the things that influence women, men and families from either doing FGM, the risk factors, or protecting the girl from having had it? And UNICEF does regular surveys across sub-Saharan Africa and reports regularly. So if you want detail about particular countries, it's a very good reference. So they found the protective factors are if the mother or the woman is able to discuss it with her husband or a friend and knows that the law will be implemented. Global debate is important, TV, media, and of course I haven't mentioned here mobiles, because that's a very important form of communication now. Men's attitude and knowledge is very important, and there have been studies showing that men know very little. They think it's women's business. And in fact, if they know more, they often want to stop it. And there have been studies that show that men prefer to have a sexual relationship with a woman who hasn't been cut. Knowing an uncut person is important too, knowing that that person won't be promiscuous, won't be wild and unmanageable as is thought. So what are the risk factors? They are if the mother or the sister or other people in the family, and particularly the older members of the family, have been cut, because the strongly held belief is very difficult to change. Even when people migrate, when they go home, they might be with the family who has held that strongly held view, and in their view for the good of their grandchild or their niece, they would take them to be cut, even against the mother's wishes. When the mother is isolated and she hasn't got support, as I mentioned in the list of protective factors, and as I've suggested, when the grandmother and other members of the extended family is influential. When there's little information and discussion about FGM, and despite what we think, there can be little knowledge of people coming over and migrating to the economically developed countries, they might not realise that it's illegal. And also that the communities have the impression it's not taken seriously by the statutory sector. So they think that if they do this underground, nobody will notice and it doesn't actually matter. So when is it done and who does it is something you might be thinking about, because as practitioners, whether you're working in the police or social care or in medicine or in health, and even if you see a child who comes in with asthma to the ED department, you have to think about the risk of that child or young person sitting in front of you. But as you can see from this chart, it happens at different ages across the world. So although 50% is carried out before the age of 5, it is different in different countries. So for example, Malaysia and Southeast Asia, it's mostly under 1 year of age. And as I said before, 50% of girls between 5 and 10 have had type 4, which is a little prick around the clitoris, which doesn't cause any anatomical or long-term difficulties. In Nigeria, Eritrea and Mali, it might be done before 5 in infancy, and then in middle childhood in Somalia and Chad. In Kenya and Egypt, it can be later, before puberty. But now, with change in practice, many girls, and particularly in Egypt, in fact, are having it in the first month of life, in fact, after delivery. And it's often done now in clinics, despite the fact that that is not encouraged or allowed, and even if it's illegal in a country. So from your point of view, even if you learnt this, when you have somebody in front of you in the consultation at school, it's no good assuming just because they're from a Nigerian family, the family came from Nigeria originally, that all of the children and all of the girls will have undergone FGM before the age of 5 and before they migrate. Because in Nigeria, there are pockets where 90% of the children have had it in a given area, in a given community, and many other areas where no one undergoes FGMC. So my advice to you is it's important to be curious and to say where you come from, where your parents have come from. Is it practiced? Because if someone comes from an urban area where it's not practiced, it won't even enter their minds. So you can't make any assumptions, and it's best just to ask. Now I want to tell you a little bit about the UK law, because in 1985 there was an act that made it illegal to have FGM if the child lived in the UK, or even to help or try and organise somebody to carry out FGM on your child for anybody living in the UK. But by 2003, people realised that many families were taking their child out of the UK back to their home country for the purpose of having FGM. So they had, in 2003, the Female Genital Mutilation Act, when it was illegal to arrange for FGM to be carried out abroad, even in the countries where practice may be legal, because there were countries at that time where it was legal. But as I said, in all countries in the world, in one way or another, it is illegal. Doesn't mean to say it's actually not done, because as you probably know, it's very difficult to always implement the law. Then in the UK, they found that if somebody went abroad to have their child cut, they would say, well, I didn't do it. It was my mother or my aunt who took the child to be cut, and I didn't give permission, and I wasn't even there. So in Britain, and I think in Canada, you cannot bring anybody to trial because the person who did it isn't here and is probably, for the most part, unknown. You need someone to accuse of a crime. You need a suspect. But now with the Serious Crime Act in 2015, even if you didn't know it was happening to your child because you'd gone on holiday, say somewhere in Africa, and your mother took your child away, you are still culpable. You are still responsible and have to protect your child. So it's failing to protect a girl from FGM. And we now have FGM protection orders, which means that if someone suspects a girl will be taken away, the passport can be seized and she can be protected. And as you can see, we must report any cases where we have a suspicion that FGM might be carried out. I think this is the wrong one. I think you might have a slide which tells you a little bit about mandatory reporting, which we'll get to later. So I want to tell you now a little bit about how common is it actually. Might be we're not detecting it in the UK, and I think in Canada as well, but how common is it? How many women and girls have actually undergone it? And you can see from this worldwide map that it's across sub-Saharan Africa where the incidence is very high. It changes all the time, so if you want the latest data, please look it up with the UNICEF studies. And you can see which is very important across Southeast Asia, where it's extremely common, and they will do what they call circumcision, which the WHO classifies as type 4. In England and Wales, you can see that after a study which tried to estimate how many women and girls there were who'd had FGM. So they used the census data from 2011, which isn't a very good way of making an estimate, but it's better than not having any estimate at all, but it cannot be very accurate. So they estimated and published in 2014 that in young people and women over the age of 15, there were 127 survivors living in the UK. And in girls under 15 years, 10,000 would have been born outside the UK and would have had FGM before entry to the country. Then, of course, there are the 60,000 born in the UK to women from practicing communities, and so they may be at risk. So as I say, we have mandatory reporting of FGM. I know you have mandatory reporting of all child abuse. We have a duty to report all child abuse in the UK, but it's not mandatory. But obviously our professional bodies, whether we're in education, police or health or social care, we have a duty to report. But now it's mandatory. So we have to report, otherwise there will be severe consequences, although I have to say there hasn't been a case tried yet to see what would happen if that were the case, because people are very aware, and if they have a suspicion, they will report it. So if a girl discloses that they'd had FGM, for example, saying they've been cut or circumcised, or there are other expressions they might use, such as suna, which is a word for circumcision in East Africa. For example, if they were to tell their teacher, they have a duty that they must report to the police. Or if you see any signs, in other words, if you're a doctor, for example, or a nurse in the intensive care unit and you have to catheterize a girl, for example, if they're really ill and you think that their anatomy is abnormal, that will be a sign where you might suspect FGM. It also includes genital piercings and tattoos for non-medical reasons. So with this mandatory reporting, how many cases came to light? How many cases did the Department of Health in England find out of women who were having FGM? And here you can see there were 5,391 newly recorded cases. And of course, that has been rather misused in the press because they're not actually new cases of FGM undergone recently in England or Wales. They are women who've come into the country having had FGM before. And as you can see, 87% of them were pregnant, and that's when it was detected, because all midwives have the duty to ask every single woman if they've been cut. And 139 of those cases were under 18. 57 of the cases were reported as being performed in the UK, and of course, from as what I've told you, that would be illegal. But data was available only in 50, and they were all genital piercings. So you would ask, what about the other 7? And in fact, we don't know, unfortunately, because there's no information, but they could be piercings, but of course they could be FGM. We're doing a study now asking all paediatricians, and there is we have a routine card, which is what it's electronic now, sent to all paediatricians, where they have to tell us about rare diseases. And every year there are about 5 or 6 on this list. So paediatricians are very good at informing us. And for the 2 years in 2015 and 2017, I asked for FGM to be put on this list. And as you can see, in that 2 years, only 138 children have been notified of having had FGM. We haven't finished analysing the data, but the vast majority of those are children who had it before they came to the UK. So you can see, although it's happening, and there are some illegal cases, it's very small numbers we're talking about, which is not the impression we get in the press. And of course, why is that? Which I'll come on to later. Now I want to tell you about our experience in the Children's Clinic in London. Because of the changes in law which I've described, because there were more children coming forward and more people being concerned as to whether a child had or hadn't had female genital mutilation cutting, we decided to start a service specially for children and young people. So in 2014, myself and Professor Sarah Crichton, you can see here next to me with the glasses, opened up a clinic with our colleagues, child psychotherapist, play specialist, a clinical nurse specialist. So a multidisciplinary clinic where we're seeing children where there's been a suspicion or a child said that they've undergone FGM. So what happens? Children are referred because they've told the teacher, because perhaps a social worker is seeing the family because there's other child maltreatment in the family and they're suspicious. Maybe someone knows that they're going abroad, they've gone to the nurse to have their immunizations and they're going on a holiday and the mother's had it because the family doctor knows that the mother's had it, so there's an at-risk child. So this mandatory reporting, they will be telling the police and the social care, the social worker, who will visit the family and then consider a referral to us. Has the child had FGM or not? So when they come to the hospital to come to our clinic, initially they'll meet with our play specialist who helps the child prior to the appointment. And in fact, before coming, all patients and professionals would have been sent a leaflet that we've written to tell them what happens in the clinic. Because understandably, people are very nervous about having this sort of examination. They think it's very painful. They think we're going to stick things inside them, interfere with what they will perceive as their child's virginity, and it will be very traumatic. But that isn't the case because it's a very brief examination and we have a quick look to see if the child has had FGM or not. Has it been a false alarm? So initially we will meet with the social worker, not the police, they very rarely come, and get the background. What else is going on in the family? Are there other issues like housing? Because this is a holistic assessment of the child. We want to know about the whole child in their environment. What else is going on for them? It's not just about the FGM, although that's why they've come to see us. During this time, the child is with our play specialist and with the parents, and she's telling also a little bit about the consultation. Then we'll meet with the parent, the caregiver, and talk to them about the health of the child, what they're worried about. And you'll see from the statistics, over 50% will say that actually their child never didn't undergo FGMC, but there has been a suspicion and they want their child examined to really support their view or their telling of the social worker and police that in fact their child hadn't had it despite the concern. Then with consent we examine the child always with their parent, although sometimes teenagers don't want their parent to be present. And we use what's known as a colposcope, which is a light on a stand which magnifies a genital area. And we can do photo documentation. We can take a DVD recording so that we could discuss the findings with colleagues for peer review. So we have a second opinion. And also, if there's a court case, there's evidence on the DVD of what we found to show that the child has undergone FGM. We explain our findings to the family and to the child, and particularly older children want to know what's happened, especially if they've come to Britain having had it done. They want to know what happened to them, what does it mean for them. And everyone is offered an appointment with the psychotherapist because, as you can imagine, it's a very traumatic situation, and over 50% of our patients did ask to speak to her. We do a blood test to all children, which we offer to check there's no bloodborne viruses, as I said before, hepatitis, HIV. And many of the children, when I'm thinking about the holistic aspects of the child, perhaps are covered and have not much sunlight, and so I would do a vitamin D level on all of them and advise them accordingly, depending on the result. We write reports, and copies always go to the parents. So this is just to show you what happens to the child, because the child is most important and is at the centre of our consultations. So while we're talking, as you can see, she is with the play specialist, and the play specialist is showing this little girl what's going to happen. So she's not too scared and frightened, and she feels in control of the examination. In the book of photographs, there's two books, one for young children and one for adolescents. This is a little actress who was very happy to be in the photographs. She has not had FGM. And you can see with the series of photographs, the patient who's coming has an idea of what's going to happen. And most importantly, we don't take all clothes off. And you can see the child's got most of her clothes on. And that's one of the great fears children have, that they're going to be undressed and it's going to be incredibly embarrassing. And you can see examining the genitalia with what we call the colposcope, which is the light that magnifies, and then you can see the television screen where we're able to record the findings. And some girls, I always ask if they'd like to have a look. Most say about 70% will say, oh no, thanks. And they'll be with the play specialist. This little girl is playing with the coloured fan, but other children might be looking at a book with her or just chatting. But some of them, actually, the teenagers really want to see and want to look and want me to explain. And many of the parents want to look also. So just to tell you about our 10-year experience, you can see this is a timeline. And you can see there have been increasing number of referrals over the year from 2006 to 2017. And particularly here, the clinic started. And then after the Serious Crime Act, in that year where it's being discussed, and there was the mandatory reporting, more and more children were referred. And not only do we see children, but we give second opinions on DVDs, photo documentation recordings taken from colleagues all over the country. So we can confirm or not or refute their suspicions, because obviously one needs quite a lot of experience. And for many practitioners, many doctors, it's very helpful to get a second opinion. The other thing this graph is showing, which is very important, is that the red is the children who have had FGM, and the blue is no FGM, a false alarm. In other words, there is a suspicion, perhaps there's been an anonymous phone call to the childcare agencies or the police, a malicious allegation, and actually we're confirming that FGM has not been done. And this chart graph summarizes, you can see of the 162 children referred over the 11 years, 75 had actually had it, but 87 hadn't. So what were the ages? The mean age, the average age that children have had it was 5. And you can see, compared with the graph I showed you at the beginning, or the chart of the different ages, that's younger, because over the last 10, 20 years, it is being done generally at a younger age. But they have come to the clinic around 4.5 years later on average from when they'd actually had it done. 85% Most had had it coming to the country before coming to the UK, and 15% had it, and this was illegal under UK law. Now to tell you what types they'd had, you can see here out of the 75 children who had had FGM over the years, most of them were type 4. So that would have been a prick or a cut. In some of them we did see a scar, but some we didn't. So we relied on making the diagnosis from the history from the mother. And mothers would tell us, particularly from Southeast Asia, where they would say they've had FGM, or they would call it, in fact, circumcision, which is a practice that they believe is a religious practice. But I didn't say before, although I was on one of the slides, this is not a religious practice. It is not a Muslim practice. It's not in the Quran, although 50% of people in some surveys believe it is something that they ought to do. And although the Muslim Council of Great Britain has ruled against it, some imams still preach it. So now I just want to tell you about a few cases just to illustrate what I say and to perhaps make it more real for you. So the first case is a 30-year-old Malaysian woman who was a resident in the UK, booked with a midwife, and the midwife, as I say, has to ask all women about FGM, wherever they come from, so there's no mistake. The mother confirmed she and her 4-year-old daughter both had been circumcised, and so, with the concerns about the 4-year-old, she was referred to the clinic. What type has she had? Did she have any damage? Had she contracted hepatitis as a result of having it? So what was the outcome? There was a normal anatomy which confirmed she had type 4, which is what the mother had explained to us, because this is the practice in Malaysia. And both parents were horrified to think that they had broken the law. They were very law-abiding citizens and they had no intention of breaking the law, and in fact then reassured us and the social care and the police that there was no way, if they had a little girl, they would be doing it again. But it's important to note that in 2012, all parents from Malaysia were urged to have their daughters circumcised. So it is very confusing for her and her relatives when they go back there. It is now, I'm glad to say, illegal in Southeast Asia, but obviously putting the law into practice is another issue. In a second case, a mother and her 4 daughters were referred to the clinic to confirm FGM in the oldest 3 and to ensure that the youngest, aged 7 and born in the UK, had not had it. This shows you the change over time, the generational change, because a 17-year-old had type 3. She had symptoms, in other words, she was taking a long time to pass her urine. And when we asked if she wanted to have deinfibulation, in other words, the release of the sewing up of the labia, the large lips, to make the urine come out at a normal rate, just normally, she refused. She was 17, she had a right to refuse, and she didn't want her body changed. We did advise her to come back to the clinic prior to her wedding night and explained why that was important. In the 12-year-olds, we saw a very small scar over the clitoral hood and no other anatomical changes. So that will be type 4. And one of the twins, who was very nervous and hadn't really wanted to be examined, but did with support from the psychotherapist, afterwards she said, "Oh, I'm normal." And we understood that her anxiety had not been that she didn't want to be examined particularly, but she was very anxious about what we would find, and also to find that she was not normal. She wasn't a normal little girl. The 7-year-old had a normal examination. The third case I want to tell you about is an Asian family, a Kenyan Asian family, and you might know that lots of families from Mumbai, which is in India, migrated to Kenya to work, and they then migrated to England. And there was an anonymous member of the public who were concerned that this family was going to subject their daughter to FGM. So there was a full investigation. But in fact, when we asked, as I advise you to ask at the beginning of my talk, ask people, what happens in your community? Do you practice FGM? And in fact, we knew that they were Hindu, Indian, and they came from a community where FGM was not practiced. And in fact, they weren't Kenyan, they were originally from Mumbai. But what was important is the social care hadn't even asked the family prior to doing the investigation. So it just illustrated the point to ask, and also to examine the child very quickly before you do a full investigation and subject the family to probably many weeks of questioning. Case 4 is a teenager who learnt about FGM in school, and we do have a full education program. And she wanted to know what had happened to her because she'd had FGM prior to coming to the UK. She was one of the girls who wanted to look at the photographs, and we fully explained what had happened to her and what it meant for her. And then she brought her sister to the clinic for the same explanation. So we found out from our clinic practice that there's significant evidence of medicalisation. In other words, the children had it done abroad and they'd had it done by a nurse or in a clinic. It was done at a younger age. And many of them, as you saw, had type 4, which can be difficult to identify because a little prick would heal. The parents were keen for their children to be examined, especially if FGM is denied. And also, if they had an investigation, the impact of the referral is significant. So multidisciplinary management is key in the paediatric FGM clinic, and it's very important that we're able to work with all our colleagues. But the other thing we noted is that there are difficulties in prosecutions across the UK and in the EU. And in the UK, as here, we have an adversarial system. So we have to prove beyond reasonable doubt that that suspect actually arranged or did themselves female genital mutilation on that child. And that is actually very difficult to prove. One of the reasons FGM has decreased in the country, and as I told you at the beginning, there are very few children who present to us or children who are detected they might have had it, is because of the work of the charities. And you can see here the logos of our main charities in Britain, and they've worked tirelessly to raise awareness, educate children in schools about FGM to decrease it. So if it was happening more, it's not so much now. It will be because of the work of the charities. And as you can see, 14 other inner city community groups who work against FGM to advise people. Another reason for the decrease and the lack of numbers that we thought we would be seeing, but we're not, is because there's been some guidance for professionals, multi-agency guidance. This is one example, but there's been regular guidance on how we need to work together to detect it, mandatory report, and ensure that the child is protected if they've had it, and certainly if they've had it, their siblings will be protected from not having it in the future. There's an e-learning program for health, which everybody has access to, and in fact, in schools, in social care and the police, they also have e-learning and face-to-face learning programs. And for all professions, it is mandatory not only to report, but to also have training themselves. How do we help parents who are going abroad? And as I said, some parents, they go and it might be their relatives who take their child. So how do they explain to their mother, their grandmother, who's convinced that this is the best thing for their child because they think if they don't, they'll be wild and crazy and won't be fit for marriage? We have a statement opposing female genital mutilation, and as you can see in several languages, that you as practitioners, when you meet a family, can give to them if they're going abroad and you think there could be a risk. Obviously, if you think the risk is very high, they shouldn't go. But this little leaflet, which is signed by members of the government, really protects families from relatives taking their children when they didn't know or give permission. And as you can see, the other languages really help here. So what's your role? Not only the health, but also police, education. If you're concerned, you need to ask the girl, oh, you're going on holiday. Do you know why? Do you know what's going to happen? And if you get a suspicion, obviously you need to report. We need to record from birth, particularly in health, because as you know, there's lots of health consultation in the family doctor, nurses who give immunizations. We need to know if the mother's had FGM, is the child at risk? And that might be the person who has the concern about it and reports. And in every borough, which will be in every municipality, small areas in the country, we need a strategy for prevention. And health, social care, police, and the charities work together to try and raise awareness and prevent this happening in the first place. So just going back to the prosecution, there was, so far, there's been 3 failed prosecutions in England. The first one concerned a junior doctor, and he was accused of stitching up a woman. And to undertake cutting is illegal, but also for women who want to be restitched so they're back to normal after having a baby is also illegal. And in this case, the court case, the case went to court and accused the doctor of performing FGM on the woman who'd had FGM in Somalia, type 3, and she was sewn up. She'd had some pregnancies before, and so she was open, de-infibulation we call it, and then she had a delivery. And they had to do a little cut through some scar tissue. And afterwards, she bled, as happens after delivery. And so the doctor had to stitch her because of the bleeding. And he only put in 1 stitch. But this was the basis of the prosecution, to say that actually he stitched her right up and this was illegal. I'm glad to say, because he only put 1 stitch in, which doesn't constitute re-infibulation, sewing her up again, he was found not guilty and the jury decided very quickly. There were 2 other cases went to court. My colleague, Professor Crichton, was involved, and in these cases, for various reasons, the fathers were accused of arranging for their daughters to have FGM, and it was type 4, because on examination there was absolutely no anatomical change, but the suspicion was high enough. In court, there was deliberations for at least a day when they were deciding what did mutilation constitute. And the court decided that in the English law, mutilation meant there had to be a change in the anatomy. And as I explained to you, in type 4, there is no change. And so they could not convict the father under the FGM law. So far, unfortunately, we haven't had any cases, because prosecution indicates to the communities that we are taking it seriously and they should respect the law and not allow their daughters to undergo any type of FGM. So in summary, I hope I've told you a little bit about the background and the types, the prevalence, our work in the clinic, and the prevention and prosecution situation in the UK. Thank you very much. Apologies again for the technical hitch at the beginning. And now I'd like to ask you if you've got any questions, which I will answer. So just go back to the top. So one question is the purpose of the examination for legal purposes or to provide ongoing health support to the survivors, or both? Excellent question, because as I see it, it is both, and I think that's very important. From my point of view as a paediatrician, it's very important that a child is healthy, is safe from disease, and obviously when I'm seeing a patient, we'll be thinking about every aspect of her health, her well-being, physical and emotional. So that is very important, the health support. And also for legal purposes, it's a second, or a concurrent reason why we need to see, has the girl actually undergone FGM? And also, what type is it? So that will be for legal purposes. So you're absolutely right, it is for both. I think there was another one. Just looking, Steve, there's another case. Case 1, their permanent residence. Was the FGM done in the UK or abroad? And were there any changes in this case? I'm not sure which what you're thinking about there, but interestingly, you should talk. You mentioned permanent residence. Oh yes, in case 1, because in fact, the 4-year-old had FGM done in Malaysia, And you're right, because when she had the FGM, the parents actually hadn't registered her to be a resident of the UK. So at the time of birth, she was neither resident of Malaysia nor resident of the UK. The parents were both residents of the UK, and they could, and they did, go to the embassy and register their daughter. But it took them a few weeks. And in the intervening weeks, she underwent FGM. So the law in 2015 has been changed so that that loophole has been closed. So you're absolutely right. There weren't any charges in this case because it was extraterritorial. In other words, at that point, she wasn't a British resident. The other point is it was, in fact, before the 2015 law. So, in fact, we couldn't prosecute the parents because at that point, before 2015, we would have to prosecute the person who did it or the person who arranged it. Just going to look for any other questions. Have you ever come across non-religious FGM done in the form of vaginal plasty? That's a hot topic. Non-religious FGM. Well, pricking is non-religious, I would say, and that constitutes type 4. And in the classification for reporting for the Department of Health, which is in the UK, and also for our study, which I talked about, we included pricking or piercing as type 4, and that is non-religious. In the form of vaginal plasty, I'm not sure what you mean. Do you mean labiaplasty, where they cut the labia, the little lips? And sometimes, very often and increasingly now, teenagers, and we know particularly their mothers, will come to the gynecologist or to the pediatrician or to the doctor and say, my child, or the child complains she can't wear tight jeans, she can't go swimming because the inner lips, the labia minora, stick out and they want them trimmed off. It's called labiaplasty, and that will be non-religious FGM. It is not advised in children under 18. It's strictly advised against in the UK. There are strict guidelines, but we know in the private sector it's difficult to regulate. And we know from the statistics that there sadly are children under the age of 18 who have had it done. And we know this has happened in the States. Someone else has talked about it and asked, is reported to be done with the adult's own consent? So you're right about that. Are we talking about a child or an adult? In an adult, in other words, anybody over 18, they have a right to do what they want to their bodies. And labiaplasty in young women over 18 is not illegal and can be done with their consent. In the United States of America, in fact, it can be done. And also, unlike the UK, a woman can be stitched up again to have her FGM back if she wants after delivery. And that is not illegal in the United States, but is illegal in the UK. Anything else? Do you have any other questions? Maybe we have a few more minutes. Perhaps I should wait in case anybody else wants to post any other questions. If anything wasn't clear or you want me to go over anything else again. I think I'd just like to emphasize for any of you working in any area, it is important that you really have the confidence to ask people. And in my experience, women from practicing communities or women who've undergone it actually don't mind saying, if you say, may I ask you a question about yourself? If you're a doctor, you're taking a family history, it's not so difficult. If you're in social care, it might be harder, but you are asking people about their own history and their own past. Another question's come up when I said using one stitch is illegal, to elaborate on that. Well, in fact, the young doctor was taken to court because they were saying that the one stitch constituted re-infibulation. In other words, stitching the woman back up again, redoing the mutilation type 3 with the stitching. And in fact, the court said that it wasn't illegal. He was not found to be guilty of stitching her up, because as you've pointed out, Betty, it was only one stitch. Oh, do you want this? Okay, I can answer one really quickly. a referral and the teenager does not want to be examined to protect her parents from any legal repercussions? Very good question. We've had 13 of the teenagers did not want to be examined, which we respected, and actually all of those had had it before they came to the UK. To protect her parents from legal repercussions, you're right, because if we find someone's had FGM and they have to go to court, nobody wants to speak against their parents, even if they feel their parents cause them harm. As we know, children are incredibly forgiving and don't want to go. So you're right, there can be cases, although I haven't come across anything that you've suggested, where a girl doesn't want to be examined to protect her parents from legal repercussions. But I think it might well happen in the future because of the 2015 Act. Well, thank you very much for your very interesting and stimulating questions, and I wish you very good luck in the future with cases such as these.